Good morning, and welcome to today's webinar, The Rural Health Response to COVID-19. This webinar is part of the Reimagining the Rural West initiative of North Dakota Governor Doug Burgum. You can find more information about the initiative, including recordings of previous webinars and workshops, on the initiatives page at westgov.org. A recording of today's webinar and presenter slides will also be available on our website later today. All attendees are muted, but you may submit questions using the attendee chat function on the left of your screen. Questions will be incorporated into the moderated discussion. Thank you again for tuning in. I will now turn it over to WGA Executive Director Jim Ogsbury.
Thank you, Lauren, and good morning, everyone, and welcome to today's webinar, Rural Health Response to COVID-19. As Lauren explained, this webinar is being produced in connection with Reimagining the Rural West, the chair initiative of WGA Chairman and North Dakota Governor Doug Burgum. This is our sixth initiative webinar in just the last 2 weeks, and those of you who have been engaged with this project know that it is being built around three central pillars: opportunity, connectivity, and community. That third pillar, community, refers to those attributes that make the rural West a great place to live and work and play. That includes access to education and sports and the arts and opportunities for civic engagement. But way toward the top of the list of critical attributes is access to quality health care. Rural health care was of paramount concern to Western governors before they had to confront the current health care threat. The rural West has endured a spate of rural hospital closures in recent years, as well as challenges in attracting qualified medical personnel and connectivity issues that limit access to telehealth opportunities. During the COVID-19 pandemic, our rural communities face additional challenges. Compared to their urban counterparts, rural health departments and hospitals often have fewer resources, less advanced care options, and fewer healthcare professionals to call on in a crisis. Populations in rural counties are older and sicker and more vulnerable to COVID-19. Those in the poorest rural counties are less likely to be insured. Mortality rates in those poorest counties are already substantially higher, and the life expectancy is 5 years lower than in less distressed counties. The gravity of the coronavirus threat is adding further financial pressure to those remaining rural hospitals that were already just scraping by. Their health systems face an alarming rise in costs as they endeavor to ramp up staff, stockpile supplies, and prepare for a surge, while at the same time they're losing revenue as patients cancel routine procedures from regular checkups to elective operations that have been temporarily suspended in many states. Also in the West, many rural communities rely on tourism-based economies, which has raised exposure levels at certain destinations in the West. One such area is Blaine County, Idaho, one of the Gem State's top tourist destinations. With thousands of visitors from around the world, Blaine County was the first in Idaho to confirm community spread of the virus in mid-March. From there, county leaders took decisive action to mitigate the spread and protect their community. Today, we'll hear from those leaders about the steps they took, challenges they encountered, and lessons that can be applied to other rural communities in the West. To introduce today's panelists and moderate today's discussion, I am pleased to introduce my colleague, Troy Timmons, WGA's Director of Strategic Initiatives. Troy has been spearheading WGA's COVID-19 response efforts, and he maintains the association's healthcare policy portfolio. So accordingly, he is exceptionally well qualified to lead today's discussion, and I'm pleased to turn the program to him now. Troy.
Great. Thank you, Jim. You gave an excellent overview of the importance of our webinar this morning. Blaine County was one of those initial hotspots, and for the experience in Blaine County to be useful for other rural counties in coming months. The reason for that is that many medical professionals expect that as stay-at-home restrictions are relaxed and we try to get the American economy back to normal, we will see an increase in coronavirus exposures across the entire country. That will especially play out in rural areas. And so Blaine County offers us a great opportunity to examine lessons learned from their experience, a very early experience with the virus, and hopefully those lessons learned will be instructive to localities and states in throughout the coming months. With that, I'll introduce our panelists for today. I would note that in addition to being the home of Sun Valley, Blaine County is also the original hometown of Peekaboo Street. And if you're a downhill ski fan, Peekaboo has I think a couple of Olympic medals, 2 World Cup downhill season titles, and probably a pretty good chunk of other associated hardware. So it's great to have Blaine County participating today. Our 3 panelists include Commissioner Jacob Greenberg, who's the chair of the Blaine County Board of County Commissioners. He's a 30-year Blaine County resident and has served as commissioner since being appointed by a former WGA director, Governor Butch Otter, in 2012. We also have Melody Boyer, thank you, and apologies, who's the executive director of the South Central Public Health District in Idaho. She's an incident commander and currently leading the COVID-19 response in the district's 8 counties, which include Blaine County, which at one point did have the highest per capita coronavirus infection rate in the entire country. Third, we have Dr. Terry O'Connor, who's a board-certified emergency physician and EMS director in Blaine County, Idaho, and has been helping lead the county's COVID-19 response. We're lucky to have him here. His insights have been regularly sought out by medical experts and in a variety of different venues, including a lot of media outlets. So we've got 3 awesome people here to discuss Blaine County's response to COVID-19. Really look forward to hearing of your experiences and then being able to engage in hopefully some really great discussion about the challenges you faced, the solutions that you had, and some of your insights and instructive knowledge for others who will likely be facing the same kind of challenges in the months ahead. So, Commissioner Greenberg, I'll turn it over to you at this point.
Thank you so much. Thanks for having us. It's a pleasure to be with you. You left out a few notable Olympians. Kristen Cooper, our downhiller, she's a silver medalist, and Gretchen Frazier, and my fellow commissioner, Dick Fosbury, who was the gold medalist high jumper at the Mexico Olympics, and he's a fellow commissioner, so I just wanted to recognize them. So for us, it's been a pretty wild story here. You all heard Blaine County is the home to a famous Sun Valley ski resort. Obviously, this is a tourist-driven economy here, and with that comes large-scale events and close proximity partying, and that's just what this virus likes. The first positive COVID-19 test results were reported on March 13th, but obviously the actual transmission occurred earlier in March. Community spread was determined on March 18th, and I have to recognize Dr. O'Connor. He's our ambulance district medical director, and I rely on him to give me information about what's actually happening on the ground, because he is also the our ER doctor and part of the St. Luke's hospital system. So we have a 25-bed hospital here, and this is just part of a greater St. Luke's system with facilities all across Idaho. So fortunately, we could divert many of our patients to other assets within that system, and the hospital approached us early on and asked if we could assist through the ambulance district to transport to other facilities in Twin Falls and Boise, which is over 2.5 hours away. So we were fortunate in that we could use some of our ambulances that are contracted through our fire departments here to assist with transport. We also hired an additional transport from Boise, so we had 4 ambulances helping transport people from and diverting from this system to other facilities throughout the state. So on March 18th, when we first determined that we had community spread, the first word that I got from Dr. O'Connor, I talked to fellow elected officials here, and what I found was that we did not have consensus about sheltering in place. And we had a couple of mayors who didn't think it was necessary. I contacted our public health department, Melody Boyer, who's with us today. She moved that up to our task force. The task force got to the governor. They called and set up a meeting for 12 o'clock that same day. We met and I explained to them that we did not have consensus. They were surprised. I asked the director, Dave Jeppesen of Department of Health and Welfare, what would be the trigger point for issuing a shelter in place for the state, and if it was community spread. We had that, and they had to initiate that order. So that order was enacted the very next day. The state, the county, the cities all made disaster declarations, and an EOC was stood up and splintered into smaller groups by my recommendation, including an elected officials group, which included the mayors and the chair of county commissioners. That group actually made a decision to further restrict the state order, and it included removing construction as an essential service. We had such a high degree of positive cases that we felt like we needed to restrict as much activity as possible. That group continues to meet 3 times a week, and we hope to continue to speak in a unified voice. After that first initial discussion about sheltering in place, we've been pretty much lockstep in our decisions, and I think that's really helped the community because it's been a consistent message. We don't have one city, acting one way and another way. It just makes for a more unified and uniform and consistent approach. So the peak of the positive test cases was around March 31st, and the flattening actually started first part of April. So our quick actions and our community actually responding to this and taking it seriously helped us come out of this rather quickly. And I'll let Dr. O'Connor speak to that when he does. But in the middle of all of this, by the way, Mother Nature decided to rattle us in the middle of all of this chaos by throwing in an earthquake. So right in the middle of all of this, we experienced an earthquake, and people were just, pretty rattled. But just like a James Bond martini, we were shaken, but our community was not stirred. So we all came out of that okay. We just looked at each other and bewildered. We allowed these more restrictive measures to lapse with the new state order. And interestingly enough, the state order included many of the items that we considered as more restrictive. And so we were allowed to let those restrictions lapse, and construction resumed as of last Monday for the entire county. And I guess I might mention that we had a couple of fires to deal with as well. We had a few wildfires, and just yesterday we had a controlled burn go out of control. And so we're dealing with all sorts of issues. Yesterday, the water system failed at one of our trailer parks, and that was into its 20-something hour. We got calls, the commissioners did, the 3 of us dealt with getting the water turned back on, getting porta potties there, having the owner rent 16 rooms so that people could actually go and wash, especially people who were in essential services. And in the middle of this pandemic, one of the requirements is, to follow hygiene guidelines. Well, you really can't do that if your water isn't turned on. So between the 3 of us and our state representative, Muffy Davis, we were dealing with this and that at the same time, and fortunately, they received the part that they needed from Boise. The first part was faulty, the second one worked, and water was turned back on last night. So, I'm on the Latinus task force, and our Latin community has been really challenged with getting information in Spanish. I think, the state is doing a pretty good job. Our local governments are doing a really good job getting everything translated in Spanish and kind of reduced to bullet points, so it's not, built in with all sorts of excess information that's not necessary. They just need to know, what are the strict rules? What do we need to do? Loss of service sector jobs and the inability to obtain unemployment for some of these people is really been impactful to that community. Our local food pantry, the Hunger Coalition, has tripled the number of people served, and our school continues to deliver lunches at a really high rate. We heard today that our Senior Connection is running out of funds, so my wife and I wrote a check to them this morning. They deliver meals to seniors, and they're just running out of funds. We're going to have to maybe consider, as county commissioners, we do contribute a portion of our funds to support senior. I think last year we contributed $75,000 to them. I think we're going to have to think about maybe doing that before our budget deliberations in May and June and setting up our budget. We may have to advance some money to that organization. People have been really giving. Our community has over 300 and some odd organizations, funds that will contribute to community needs. And so I think we're going to be okay with that, but still people are struggling, and so we're finding ways to accommodate for that. Some of the people in that community are afraid to come out, and obviously some of them are afraid to reach out to governmental websites or organizations. And so that Latinus task force has been really crucial to that community. Kids are delivering some of the school lunches by bike to families. And so we're finding ways to reach out to them and make sure that they have the resources that are necessary through the nonprofits and through other organizations. We have a couple of research studies planned to determine seroprevalence. Dr. O'Connor can elaborate on that. The governor just announced a plan to reopen the economy. He's called that Rebound Idaho. And if you want to see what that plan is, I guess they touted it as a kind of a beacon for other states to follow. It's called rebound.idaho.gov. The way back includes testing coupled with social distancing, isolation, and contact tracing. We have a meeting set up today, Dr. O'Connor and I and Melody and my two other commissioners, to have a discussion about what that looks like moving forward so that we can ensure that we are successful and that we don't have a resurgence of this virus. And I'm looking forward to having that meeting this afternoon at 2:30. The governor has allocated an additional $7 million to local public health districts to ensure that they have adequate staffing and resources to make this be successful. A Blaine County Recovery Committee has been formed, and businesses have been asked to develop operational plans consistent with social distancing guidelines and to be ready to be open or reopen at the appropriate time. What I would say is that there are unintended consequences with some of the decisions that we made. We asked the governor to impose a self-isolation order on Blaine County, and 19 minutes later had a press conference that told the entire state that we were going to be in an isolation order, that Blaine County would. We really didn't have enough time to set up our own press conference and let our community know that we were planning this. It was still in the discussion stages. And so everybody rushed the grocery stores And I understand why. They think they're going to be in lockdown for 2 months or more, or 2 weeks or more. And so they wanted to make sure that they had the appropriate supplies for their families. Unfortunately, none of the grocery stores knew. And so they were just inundated with people. When we allowed the construction industry to go back to work, we had a 18 line item guidelines for them to reopen, including assuring that they had hand washing stations for their employees. And yesterday, when that trailer park ran out of water, we called the local waste and sanitation company, to order some hand washing stations. But unfortunately, or fortunately, all of the construction companies had rented those out, so there were none available for this other situation. So it's been like that, a multi-tentacled decision making and unintended consequence situation, and we just have to be sometimes reactive, and most of the time we'd like to be proactive and think ahead. We do have a group of lawyers that are offering free service to those in need, and the Latin community has taken advantage of that in negotiating rents and mortgages with landlords and banks. So that's really been helpful, and I really appreciate that from them. Hopefully, they don't use them to sue us for anything, and we haven't done anything wrong. So I hope that doesn't happen, but it was kind of a thought that crossed my mind. The community really appreciates what our first responders and frontline workers are doing, whether it's hospital workers or first responders or our emergency communications, people working at grocery stores, that keep the community going, the uh, restaurants that have stayed open and are now making deliveries or curbside pickups just to keep things going. And the community howls at 8 p.m. every night to show their appreciation for frontline workers. I go outside with my dog, and the dogs are howling and people are howling, and they really get a sense of community and togetherness, even though we're in self-isolation. So I look forward to the next phase. We're going to work hard to make sure that that's successful and everything is in place to make sure that we are successful, and I know we will be. This is a community that excels at that, and I'm confident that we will be successful. So with that, I'll turn it over to the next speaker, and thank you for having us. Really appreciate it.
Thank you, Commissioner. Why don't we have Melody go next?
Okay, can everybody hear me okay?
Yep, you sound great.
Okay, great. Thank you. Thank you, Commissioner Choi and members of the audience for taking the time to be here with us today. And in the next 5 to 10 minutes, I'm hoping to share with you our experience in COVID response through the public health lens. I hope to give you a sense of what it's like responding to an unprecedented and novel disease outbreak. I will share with you some of the strategies we used in a coordinated response and the challenges we encountered and the lessons we learned from our experience. I'm hoping that by sharing our story, you will get a feel for what to expect and what actions you can take now, so you will be better prepared when the time comes. Would I be able to advance my slides?
Hi, Melody. Yeah, you can click on the bottom of your screen. There should be some arrows that pop up, or I can do it for you if that's easier.
Oh yeah, here. Sorry, I got it. Okay, great. So first, let me tell you a little bit about our public health district. South Central Public Health District is located in the south central part of Idaho. We are a district of 68 full-time and 10 part-time employees, serving 199,000 people in our 8-county area, which is about 12,000 square miles, and it's about equivalent to the size of the state of Maryland. We have one main office in Twin Falls and 4 other satellite offices and a clinic in the surrounding counties. We are governed by a board of health, which consists members from 8 counties plus medical consultants. These members, they are either appointed by their county commissioners or their county commissioners themselves. We're very fortunate to have Blaine County Commissioner Anjani McCleary serving on our board. She's a very engaged board member and a huge supporter, and Blaine County in general is a huge supporter of public health. In fact, she was very instrumental in making sure that public health preparedness and emergency response is one of our high priorities for our district. Additionally, we have a pre-established incident command structure that is scalable and it's ready to be activated in case of emergency. Now, let me tell you a little bit about Blaine County. As Commissioner mentioned earlier, it's home to the famous Sun Valley Ski Resort. And it's about 80 miles north of our main office in Twin Falls. Has a population of 22,600. And it is served by a critical access hospital, which is also part of a larger health system in Idaho. So they do have the benefit of be able to transfer their critical patients to St. Luke's Magic Valley in Twin Falls or St. Luke's Regional Medical Center in Boise, as Commissioner Greenberg mentioned earlier. In addition to that, our leadership and our public health preparedness program staff have a very strong relationship with Blaine County commissioners and the emergency management and first responders in the area. We meet and train and exercise with them on a regular basis. And our hospital preparedness program is in constant dialogue with the hospital preparedness program management and first responders. So as you can see, the groundwork was already laid for a collaborative, coordinated response in case of an emergency. So let me give you some perspective and timeline on the unfolding of events. And on the bottom of the page, as you can see, at the beginning of the year, we were monitoring the situation as the coronavirus outbreak was happening in Wuhan, China. On January 30th, the World Health Organization declared coronavirus as a public health emergency of international concern. At that point, our district started monitoring and response planning. As the event progresses, we're starting to have weekly meetings and we're updating our isolation and quarantine order to make sure that we will be ready to put that to use if we need it. Then we start having dialogues and conference calls with the Idaho Department of Health and Welfare and the Idaho Office of Emergency Management to trying to get information flowing, guidances on what we should do in case of a response. And we start engaging the public using our social media platform. And as the first case of a coronavirus was reported in the United States, we started our stakeholder meetings with each of the 8 counties. We held our first Twin Falls County stakeholder meeting. We met with commissioners, mayors, first responders, medical, hospital personnel, school officials, law enforcement, to talk to them about how we will share information, how we will work with them, and how we are going to work together in a coordinated response. As the World Health declared coronavirus a pandemic, that was also the same day we had our shareholder meeting with Blaine County. The same important players were at the table: commissioners, mayors, hospitals, medical personnel, EMS, schools, and law enforcement. I felt that meeting that day was very, very crucial for how we carry out the rest of the response. We had a very open and frank discussion with the mayors and the attendees. We understood what are the pressure points of a potential response. We talked about how best to respond in case of an emergency. And we also, from a public health standpoint, and for me personally, I gained a very good perspective on what kind of help the county will need in terms of, in case we have to implement a public health order or measure in a very quick manner. So 2 short days later, Idaho had its first case of coronavirus, and it was in Ada County. And later on that day, I will never forget, it's Friday the 13th at 7 o'clock at night, we got our report of first case of coronavirus in Blaine County. So I quickly called my incident command team back together in the office, and we started the epi investigation right away. And then our incident command team started working together and activate our incident response plan and putting together a 24-hour plan. And we were all in the office way past midnight. And then we also, because the meeting we had with Blaine County, we knew by talking to the commissioners that when the first case hit Blaine County, we will want to have a joint press conference. So the next morning, we traveled up to Blaine County, and at 1 o'clock the next day, we had a joint press conference with Blaine County commissioners and South Central Public Health. And we felt that that was very important for us to get the information out, to get everybody on the same page, so that we can notify the public of what's being done from county and public health joint efforts. And we issue a press conference, press release shortly after our press conference, and we updated our website and social media and activated our call center in anticipation of being flooded by information requests from the public. And Blaine County, as Commissioner Greenberg mentioned earlier, was very decisive, and they, as soon as the community spread was identified just a few short days later, they worked very quickly. I helped in this situation by putting them together with Idaho Department of Health and Welfare, and I was in communication with the Deputy Attorney General to help Blaine County to put together this shelter-in-place public health order in a very short turnaround. We had less than 24 hours to get that document done. And everybody was working late into the day to get that done. And Blaine County School District was very decisive as well, and they closed the schools the Monday following the first confirmed case in Blaine County. So as you can see from these graphs, the very top is the epidemiology curve for our response. The orange bars are the cases from Blaine County. And this is a response curve for all 8 counties. But as you can see, Blaine County pretty much dominated our response effort, as at one point it peaked over 450 some cases in a very short time frame. And as you can see up here on top, Blaine County issued the shelter-in-place order shortly after the community spread was identified. And also, as you can see, as that order put in place, there was a very sharp drop in the onset of spread of the disease shortly after that. So good job, Blaine County, especially Blaine County residents, for doing a good job doing social distancing to prevent the further spread of coronavirus. And as you can see on top, on the bottom left of our response hours, these are bar charts of the number of hours surged from just a little over 100 hours where we're doing our preparation in February in preparation for the response, versus when we actually put the hours our staff put in the middle of a surge and response. And just to let you know, we don't have a huge epidemiology nursing staff. We only have a total of 8 nurses in our eight to serving our 8 counties. So those 8 nurses, along with 8 supporting staff. So those 8 numbers, including the managers as well, they worked day and night, 7 days a week to do the epi investigation, the contact tracing, to notify the people so that they can be on quarantine, and also to man the phones so we can answer all the calls and emails that's coming in from the public. So this is a huge, unprecedented response. On a normal average day, we usually get 1 or less disease outbreak and investigation. But at the peak of our response, we were dealing with over 100 cases that we need to investigate and contact trace. So that just gives you a perspective of what it's like responding to this coronavirus. It literally feels like we got hit by a tsunami. And that's just what it was like. It's tremendous. So again, some of these strategies, very quick and decisive decision on Blaine County part to put that shelter-in-place order. And in fact, Blaine County was the first county and the first time in the history of Idaho to issue such order. And the Blaine County order eventually served as the model for the state of Idaho, which the governor decided 6 days later to implement a stay-at-home order for the entire state. But because Blaine County had already developed this template, so it was very easy for the governor office to make that transition. And additionally, there was a huge amount of information shared with the public via our social media, website, and call center. And as Commissioner Greenberg mentioned earlier, the Spanish language was very important for us to communicate the same message to that population and that demographic. And I felt like our public health information office did an excellent job to making the bilingual material as available as possible. And also, Blaine County has been hosting town hall meetings with their citizens, and that's been very valuable. And in the middle of this response, I had to move a lot of staffs that were temporarily not out of their regular jobs of environmental health or doing community health and promotion into contact tracing, into answering phone calls to meet the needs of the public. Additionally, we sought out help from our medical reserve corps members. We also gotten volunteers from hospital staffs from our local hospital. And we were very vigilant of gathering information and verify the PPE availabilities. And we're at all times trying to maintain that situation awareness and sharing our common operating pictures with our community stakeholders. Here are some of the examples of what we keep an eye on. We look at our tests. So these data are a little bit dated. They're from a couple of weeks ago. What we look at it is testing availability. What are the beds, hospital census, beds availability, especially ICU beds, ventilators availability, inventories, PPE, and make sure that we have enough respiratory care practitioners on staff to take care of these very sick patients. Additionally, we also looked at our regional hospital and our critical access hospitals in our health district. Look at what are their surge plan, what we can do in case of a huge medical surge. We also quickly realized that staffing resources in terms of equipment are going to be a challenge for us. And so that we are aware in case we need to respond quickly, we can take actions to seek help for those resources. Some of the challenges we faced are the speed and the magnitude of the initial response. We have never imagined we will be dealing with over 100 cases of investigation and contact tracing in one single day. Initially, the testing was taking 12 to 14 days to get results back, which kind of difficult because the batching of these results. So in any given days, we can get a huge number. And we found that trying to keep volunteers trained and manage the hours of volunteers sometimes can be challenging, especially on weekends where you were counting on a volunteer to show up to do their job, and then for whatever reason they're not able to make it. So we have to do a lot of last minute adjusting. And there's a huge amount of data we're collecting from our investigation and contact tracing to manage that database, and then to put out the epi curves and the information that's digestible by our county commissioners, by our community partners. It's very labor intensive and takes a lot of time. And then just the fatigue from my staff working 7 days a week, long hours every day. That is kind of wearing, and that's something that I need to be very cognizant of. What we learned that is we need to really be very careful, watch out for those signs of burnout, and we need to project our staff needs 1 to 2 weeks in advance instead of wait until the last minute. And I made sure that we had a designated safety officer and a health condition monitor in our district to talk to staff, to send out messages about the importance of health and safety. And that really helped manage the anxiety level of my entire staff. We used multiple platforms to communicate and engage our community partners and the public. And we also tried to make different languages as available as possible for serving different populations. And also I found that the communication is so quick and important, and often I am constantly on my phone, texting, answering my emails. And for the very first case of confirmed COVID, for the very first case of death, and for the very case of community spread, I personally made a point to call our commissioners to let them know and answer their questions and make sure that our community is aware of what's going on. So the strategy going forward, what we're going to do is, as Commissioner Greenberg mentioned, that the governor is lifting the stay-at-home order as of April 30th. So come May 1st, what's really going to be very crucial is that we have very quick turnaround for our testing so that our public health staff can respond to these hot spots and do the investigation, the contact tracing, and to kind of contain these hot spots so that we don't have further disease outbreak. And so to handle that workload, we are in the process of hiring temporary staff to handle that. And there will be serology tests in Blaine County. And still, we are telling the public and everybody that social distancing is the most effective public health measure right now. And we are going to reopen the businesses in stages so that we can prevent a second wave of disease outbreak. So with that, I'm going to pass on to the next speaker for his presentation.
Thanks, Melody. So we'll turn to Terry, I believe, right now. Dr. O'Connor, you're up.
Thanks, everybody. Yeah, I'll try to keep it pretty brief. I think it was a great overview by both Commissioner Greenberg and Melody with our public health partners. So again, I'm Emergency Medical Services Director for our fire agencies here. Our ambulance service is contracted with fire agency. There's no private industry ambulance service here, and it is not a hospital-based system, but I also happen to work for the local emergency department, which is part of the St. Luke's hospital system, the small critical access hospital that was referenced to previously. And they do have their own transfer ambulance service as well within the hospital system. But as Dr. Greenberg said, we had to exercise some flexibility going forward. I'll just do a quick run through from my perspective, both working on the front lines, working in management of logistics within emergency medical system, incident command structure, and throughout all of that, as the challenges has been evident for all clinicians out there, is just trying to digest the rapidly evolving literature on this topic, effectively like trying to drink from a fire hose throughout on all the extra hours that were demanded of us as well. But I will comment as far as where we've been. I think it's really important to highlight back to the chart that Melody had shown earlier. Those stay-at-home orders were initiated really at the time that we first started seeing some of our first disease. It's a little bit confusing to look at that chart and not realize that those bar graphs were based on the time of symptom onset. Effectively, we were starting to converse and worry about this while there were numerous individuals in our community that were already symptomatic with the disease, but were not presenting to care. And I think that's one of the really important take-homes, is that if you are not actively looking for this as a public health provider, as a hospital, it is going to come to you. And when it comes to you, it is very likely going to be a bit too late. We very nearly reached our medical capacity as a hospital system within those first few days. I was involved in those first few meetings in that week. I was working night shifts that weekend of Friday the 13th. And literally in one shift, I had to watch half of my ER staff get quarantined or sent home because of an unrecognized exposure to one of those first positive COVID cases. I watched all the rooms in the ERs get locked up for over 2 hours because of evaluation, decontamination processes that we had to abide by, because we did not have a tent system for drive-through testing set up. We had multiple critical care patients that came through, including a gunshot wound to the chest, but also critical COVID patients requiring intubation that required some basically some ingenuity on the fly to mitigate our exposure with those patients. There was another subtle presentation to the ER that night with primarily a gastrointestinal disease who ended up being a COVID positive patient, but who had a cardiac arrest in the CT scanner. Of course, all well-intentioned hospital providers came in to assist with resuscitating that woman. Her life was saved, but in one incident, we had 17 more hospital personnel exposed to what ended up being a COVID positive patient. As you may have heard in the lay press, unless you're really filtering every single patient encounter, as there might be a risk of COVID, exposures can happen, and accidental exposures can happen. The symptom presentation is not as straightforward as you would think it is. So if you're waiting until you see a symptomatically obvious case of COVID, it's probably too late. After navigating through that first really tough series of night shifts on that weekend, we started to see our caseload grow and grow. And we also lost more and more hospital personnel. We reached a point where we were probably lost a little over 25% of our hospital personnel, either due to active illness or having to be quarantined due to exposure with subsequent positive cases. And as you know, and as was mentioned before, what was really challenging was the lag time in results from these tests. So some of these cases, some of our healthcare workers were exposed sometimes 10 to 12 days before in cases that weren't quite obvious to them, but subsequently found out that they were caring for a COVID positive patient. So it also required realizing that possibility was out there, required a real change in a paradigm in regards to our personal protective equipment practices, not only with cases that we thought might have it, but effectively just starting to wear masks and PPE for every patient encounter as the situation was accelerating quite rapidly. We had to internally triage our resources to the point that we could redirect resources primarily to the front line, the emergency department, setting up a drive-through tent testing, and then also effectively a COVID clinic for follow-up. So essentially a clinic that was set up to see people that we knew had active disease to make sure that they were doing okay in the course of their disease. 80% will manage the course of their disease okay, but throughout the course of their recovery, oftentimes a week or 2 weeks in, they may have a decline where they may require hospitalization. But you don't want to admit all those people to the hospital just to find out, obviously. So we had to create an improvised system to be able to be accountable to follow up on our known cases in the community, and that was stood up. But we also had to close all of our elective procedures, as you would imagine, and we did have to close our inpatient ward because of critical shortages in staffing. Staffing shortages were so severe at one point that we actually had to rely on staffing from our outside hospitals to come in and pinch hit for doctors that were put on quarantine and nursing staff that were put on quarantine during that period of time and during the highest surge and also the highest acuity. And in addition to that, I'll reference back to Commissioner Greenberg's reference to expanding our transfer capacity. The hospital system prior to that point had one ground unit, which was available most of the time, but not all the time, for transfers interfacility. We do have an aeromedical capability, fixed wing and a helicopter on the roof of our hospital, as you would imagine. But in the initial stages here, we were trying to limit contamination, obviously, to the aeromedical team. But we quickly would start to have 5 to 7 transfers a day, vast majority of them being COVID patients that would require ICU level care. And having closed down our inpatient ward and also being a critical access hospital, the best care available really is long-term in an ICU setting. So we were concentrating, trying to get all those individuals out. And it really was, it was just effectively an audible that was called on one fateful day when we had a critical load of, I think it was 5 simultaneous critical care transfers that had to happen right then and there. And the call was made from the incident commander in the hospital system to me and to my colleagues within the stood up incident command structure for the EMS system. And effectively, we called from our volunteer firefighter ambulance drivers and basically put together some transfer ambulance services and were able to get through that night. But then that quickly made us decide to put up a task force just to help facilitate our transfer resources, which grew to include the hospital-based transfer resource, a contract ambulance that was referenced by Commissioner Greenberg, and effectively 3 transfer ambulance staff just by EMS personnel from within the county, included basically stripping down existing ambulances to make them easy to decontaminate and clean up after running these transfers. And that system worked quite well, and it was impressive to see that get stood up and really helped us out during the peak of our wave. So after all was said and done, we moved through this not having exceeded at least any medical capacity within our system. We entertained and started thinking about crisis standards of care if we started to get overwhelmed within the hospital. But thankfully, everybody that needed a hospital bed got one. Anybody that needed to be in the ICU got one. Anybody who needed to be intubated was able to be intubated. And we even refined our critical care and brought on our anesthesia colleagues to help with basically operationalizing and really making the critical care of a COVID patient protocolized to a degree that we had an immediate team set up and everybody had a task to how to attack this, very similar to how you would approach a trauma patient with a standard protocol. We did the same with our critical COVID patients, which really helped enhance our quality of care as well. And that was stood up within days, which was impressive to see. Where we are now, having navigated through all that, as today we have 517, I believe, positive, I think 516 positive cases. We, over the course of this, we tested about 5% of our population with PCR. The turnaround times of those tests have obviously improved over time. Melody was talking about this very difficult time where we're waiting 10 to 12 days. We're now really looking at a 1-day turnaround time. And we also have a in-hospital point of care unit that can give us an answer within 15 minutes if needed on critical cases where it's really important to know right away. We've been able to navigate out of this first wave with a case fatality rate of less than 1%. And now we're back to having a good cushion within our medical capacity. Our inpatient wards opening back up. We've started to do elective surgical procedures again, orthopedic procedures. We have full-time clinic open again for non-COVID related patients. We have some of our subspecialty clinics open again. And we have, as of yesterday, we had 50% of our ICU capacity open within the St. Luke's system. 91% of our ventilators were available. 52% of our hospital beds were available. So looking forward and where we need to go, I'll just reiterate again, I think objective number one for me is expanding testing. The turnaround time has improved quite a bit, but we really need to be testing within the community and expanding our criteria for testing. With a scarcity in the resource for testing, we were limiting it to patients that had known contacts or had symptom complexes consistent with this disease process. And we had to unfortunately exclude family members or members living in the same household unit as other known positives. We just had to tell them that assume that you're positive as well. That was unfortunate that we had to do that, but it was to try to help maintain a scarce resource at that time. We really want to be at a point that we can offer testing to anybody that has an exposure, that has a symptom that could be consistent with the disease, but really we need to start getting to a point where we're doing sampling of our highest risk community members. So that would both be our hospital and EMS personnel and our high risk facilities, which would include our assisted living facilities and skilled nursing facilities that are in the county, which thankfully avoided many high cases. I will add that we did integrate with the medical directors from those units and made sure that they were following best practices. I know our public health district was doing that as well, and also our hospital staff were helping because we knew that that could have been a catastrophe as it played out in many other communities like in Washington State. But we need to go to those communities now and those centers and start to offer some testing to make sure we're not capturing any hidden pockets of disease going forward. Of all the tests we deployed over the course of this, roughly 40% were positive. It was a phenomenally high positive rate for the tests deployed over the course of this first wave. We're now down to about 15% over the last week. If you look at best practices guidelines based on case communities that are, or countries that are doing it well, like South Korea, you really want the positive hit rate per test that you're doing for active disease to be quite low. I'd like to see 10% or less. We're at 15% right now, and we're working on options to try to expand our testing capacity and sampling in the community. So essentially, you have sentries out on the front looking for this enemy to come back instead of waiting it for just to come rushing up on your doorstep. The seroprevalence is an important, I think, communication piece. We're partnering with some partners at the University of Washington. We have partnerships with the University of Washington as a training site, both for the medical students, but also we are all instructors for their emergency medicine program at the hospital here. But we also have some other professional connections. I've been participating in symposiums, critical care symposiums at University of Washington throughout all of this to stay abreast of their developments, what they've been seeing in Seattle, and also to give them perspectives from a rural care and transfer issues. But in that, and with some local partnerships and connected community members, we've been able to partner with the Cancer Center, the Hutchinson, the Fred Hutch Center, and are working with their gold standard serology evaluation materials to get a good randomized sample study off the ground here, hopefully in this next week, to really get a good baseline idea of how many people actually had seen this disease and may not have even known it. And it's important to do that study as best as possible. Make sure you're not just opening up a day where people come to you and you sample them. Those are the people that have the freedom, the time, and the resources to come to you. You really need to try to randomize it as best you can to be representative of the county at whole to get a sense of what the prevalence is. And I think that's a really important communication piece going forward because it does two things for your community. One, you now have a new talking point to demonstrate how many people were infected and never knew it. You're certainly going to get some positives of people who weren't able to access testing or may have been so subtly symptomatic that they didn't think to get tested. I think that's an important piece to convey in regards to risk of this coming back and the responsibility of health districts and hospital systems to do surveillance sampling, and then to expose what your risk is going forward. As we know, for all communities, if you've looked at the data that was acquired from prevalence studies done in New York and in California, certainly the vast majority of people likely have not seen this disease, which means if you're not prepared for it, if you're not worried it's going to come, then it could come just as bad as it did in our first wave. So I think very much our community has buy-in, having seen this happen. I think one of the benefits of a small rural community is everybody's connected to somebody else at 1 or 2 degrees of separation often. And so what we were saying was quickly consistent with what a lot of people were hearing in the rumor mill as their friends or their friends of friends were falling ill of this disease or being hospitalized. We also had some young individuals in our community who were gracious to actually tell their stories to help diffuse some of this, I think, misperception that the younger demographic cannot be affected by this disease. We had a number of 20-year-olds that had to be hospitalized during our wave. And looking forward, I've really been reaching out to public health, and it'll be something that we need to develop and help. I was happy to hear that the governors will have access. The governor will have access to money and funding to help bulk up both the contact tracing capacity, but we need to consider and discuss some innovative opportunities for tracing of disease, whether they be deploying some of these app tech maybe you've heard about, also taking advantage of some very well-meaning both clinical providers who have volunteered their time to help with contact tracing. I've had many of my personnel offer to do home visits, contact tracing, follow-up in a community health EMS to really help track and contain all future cases as best as possible. And then on top of all of this, we've realized that we, for better or worse, with this big that hit us, and with being a connected county, this in the end turns into a good opportunity for us to try to expand and share things as best as we can, both with the scientific community, but with public health and public policy community. So we're doing whatever we can to make our findings discoverable for the greater community at large. So hopefully you guys can pass a little bit of some of our lessons along to others that you integrate with in your communities at home. So I'll leave it at that to make sure we have some time for questions for everybody.
Great, thank you, Dr. O'Connor. And actually, I'll direct the first question to you. It sounds like what you experienced that first weekend was just a perfect storm that would be a great or really bad horror movie. But one of the questions that came through was, so you had a number of staff that were exposed during that sequence, and the question is, can the data from those exposures to your staff and the exposure and infection and illness rates inform anything about the broader question of infection rate that may help inform other elements of the crisis generally?
I think that's a really difficult one to say. I mean, if you're referencing and just specifically the healthcare providers, at the time that this happened, effectively we were probably already in community spread. We confirmed community spread. Actually, on one of those night shifts, I actually saw the patient who confirmed the fact that we did have community spread. He was not connected to any other outside county that had the disease, wasn't connected with any other known positive disease, and he was kind of the sentinel case to prove that, and that happened in that same shift too. So any potential exposure, I mean, we subsequently did not, any of those 17 personnel that were put on quarantine, I think a few smattering of them did end up having symptoms of disease. None of them became critically ill, but even if they did, it would be very, very difficult to link any hospital exposure as the likely culprit versus a community exposure at that period of time. We effectively went from it could have been anywhere to then responding to clamp it all down right away. So I think it really would be hard to differentiate that. I think as far as the relative risk to hospital staff members, that's an important question looking forward that can be addressed in a couple different ways. One might be to look at the relative prevalence of antibodies for frontline healthcare workers versus a population at large, which could be something that could be extracted with some of the studies we're looking at doing ahead here. Other possibility, which I hope some other federal agencies might be willing to entertain in tracking our community in a longitudinal fashion, would be to see both the development of antibodies, the durability of antibodies, and if that conveys any protection to hospital staff over their work setting. These are things that are unknown right now. The answers to
Yeah, okay. Maybe I'll ask Dr. Boyer to jump in on some of the same question, or just respond to that, and have in the different counties that you're involved with, have you seen similarities to what Blaine County has experienced, or was the bulk of it there in Blaine County? And then maybe more generally, how are the states interacting with each other in terms of response and the shifting of personnel, especially if you get into a situation where you've got a large chunk of a county's workforce that has to isolate?
So as far as the response, the epi curve that I showed you earlier, let's see. The bulk of our cases were in Blaine County, mainly because it's such a unique characteristics that Blaine County has, with a lot of out-of-state traveler, international travelers. It's a ski resort, it's a destination place. So and it is one of the first counties in our district to have this outbreak. And because the experience of Blaine County, and because the quick response of Blaine County, and then Governor Little put the shelter-in-place order in shortly after that, the rest of our counties did not have the similar experience. First of all, they have a very different demographic, and secondly, because the shelter-in-place was in order. And our biggest population center, which is Twin Falls County, up to now, they do have 124 cases, but because the social distancing and the order governor put in place, the epi curve is much flatter, and it's nowhere like the spike that we saw in Blaine County.
Okay, and what kind of, again to you, Melody, so is there planning and coordination in case you needed to move personnel from one facility to another, or even across county lines? And is there provision for that in case you get moving forward, in case you get a hot spot in one area or another?
Oh yeah, good question. So what's unique about our public health district is that we are already a multi-county agency. So a lot of the preparations we do is the same for each county. The only difference is how we respond. I'll give you an example. When we did the stakeholder meetings, we went to Blaine County, but we also we cover all the other counties. And as far as how we respond, it will be tailored to those. Our district serves all 8 counties. So our response to, say, Camas County, which is basically a frontier county, has a population little over 1,000, and they did have one case. So we will tailor our response based on that scale and their needs, which in their case, with one case, just the contact tracing and, making sure that the ill person is self-quarantined. Whereas Twin Falls County, they have more cases. Their needs are different. In Twin Falls County, we did not see the spike, but we did see some long-term care facilities were having issues of employees were ill, therefore passed the disease on to the residents and unknowingly, and then there was flare-ups in these long-term care communities. So our district reacted very quickly in conjunction with the local hospital. We were on this task force to specifically target the long-term care facilities to facilitate quick test turnaround and making sure that the infection prevention was done and the PPEs are provided to the health care workers so that they are not further spreading the disease to the rest of the residents. And of course, the local hospital, St. Luke's here, provided the providers and the nursing staff to do the testing and medical advising. So yeah, it's a coordinated effort, but that's what Twin Falls County needed. And that's how we will respond to different counties. And we are also using the best practices we learned from our experience from one county and apply that to the other county. Another thing I learned is that with smaller counties, they usually have part-time emergency managers, and their elected officials may not have the same experience like Commissioner Greenberg and Commissioner McCleary and the Blaine County commissioners and mayors. Then there will be more support and guidance provided to these smaller counties. But as far as being able to cover all 8 counties, I felt like we're in a good position to do that.
Okay. We have a couple of questions for Commissioner Greenberg, and I guess the first one would be, as you start taking steps to reopen the county, what sort of coordination are you having with your local public health folks, interactions with the state, and do you feel like you've got the tools you need to make good decisions as you start to take those steps to reopen the county?
So we've had this conversation, Dr. O'Connor and I, and St. Luke's Foundation for many weeks about looking forward. We're trying to make provisions for what's to come, and so we do have a list of protocols that we'd like to follow in reopening the economy. And the governor laid out his plan yesterday. We just had an opportunity to review that. He meets with the cities, the counties, and legislators once a week. So we had our meeting with him yesterday. I think the plan is a good one. I don't know that we have all of the pieces in place to be able to execute this just yet, but we have a meeting planned this afternoon at 2:30 with my fellow commissioners, our emergency manager, Dr. O'Connor, and Melody and her staff at 2:30 this afternoon to talk about what that looks like. So we know what we need to do. We just need to have the resources available to do it. We have to have enough people to do the contact tracing. We have to have enough resources to do the testing itself. And that includes, like you've heard, nationwide, the pieces and parts that go with testing, not just alone the sending it to the lab and getting the results. So there's that. There's the social distancing, the isolation that needs to come with this when you do find a positive test. So we have it outlined. We know what we need to do, and we just need to have the resources available to do it. So, and I feel confident that when the time comes, we will be ready. We're working with local groups. Our long-term recovery committee has a business group, and we will be working with them to make sure that businesses have a operating plan that considers these social distancing and hygiene guidelines are in place. And I also forwarded the National Association of Restaurants outline for reopening of restaurants to Melody earlier so that we can get a template to all the local restaurants so that they can follow these guidelines when they do reopen. So yes, I think we have a good plan in place. We just need to get the tools in place. And I know that our community is ready to do this and do it right.
And this might be a related question. You had mentioned earlier that you've already dealt with a wildfire in Blaine County in this year, and I know there's a lot of preparation around how to address wildfire, dealing with wildfire crews, and so I guess the question is, from your experience with the fire you've already had, do you have any good suggestions for folks in terms of the preparations that ought to be taking place at a local level, both for emergency response, exposures, dealing with exposures if they arise, the social distancing that's involved with between crews and local populations, and things just as simple as trying to feed folks that are doing the wildfire response?
So we've had in the past maybe 10 years, we had 2 large-scale fires that required an incident team to show up, and these were over 150,000 acre events. And so we had maybe 1,500 personnel here at one time. And typically in those large scale events, they'll arrive with their own kitchen. And so they do the food ordering, they do the cooking, and they basically camp out somewhere. And so I think with that, they're going to have their own protocol for social distancing and how to address issues. And we'll do the same with them when we interact with the incident command team as local elected officials. Will become part of that team. And so I think that will be pretty well established. We do have a meeting set up. Our regular commissioner meeting is on Tuesday, and I've invited BLM and Forest Service to that meeting. And part of the discussion is going to be restricted camping and restricted fires, so that we don't have any, human-caused fires if we can help avoid that, obviously. And then the other ones that are naturally caused, like from lightning, et cetera, those are things that we just can't avoid. But our fire departments, Wood River Rural Fire Department and the Ketchum Fire Department, are the contract holders for our ambulance district service. And they know full well what it means to socially distance, et cetera, how they operate under those conditions. So for the ambulance district, they also are fire departments. So for the local fires, ones where they do any kind of structure protection, I think they know exactly what they need to do, and they have, standard. They've changed their standard operating procedures to incorporate social distancing. As far as the big crews that come in, hopefully they have been advised of the same, and our interaction with them will be guided by the social distancing guidelines.
I'll add on to that. Just our incident command structure within the EMS system, which is effectively our EMS and fire services. Over the last 2 weeks, we've invited our other fire suppression partners, both at the Forest Service and the BLM. And at our meetings, we're doing a formal situational kind of status with them, and then reviewing kind of operational logistics and the topic of how to mitigate and or get testing to any of those crew members if they get sick. Those discussions have begun as well, and making sure they know where they go to get tested, that they have appropriate ways to distance, also making sure they're not encouraging any of them to come when they're ill. So we have begun to integrate. Again, it's just trying to think ahead that it's perhaps inevitable that the disease may impact some of these fire crew resources into the months ahead.
Very helpful. Out of respect for everybody's time, we're at the hour and a half. I have one quick question left for you that hopefully we can do bullet responses on. And that's this: if there's one piece of advice that you would give to folks who may experience surges in the coming weeks and months on how to prepare and address those circumstances, what would that be? And your answer cannot be communication, because all three of you have expressed the importance of communication between different layers of government, different entities that are out there, between medical community, just communicating to the public the importance of this. That's been a theme that all three of you have echoed already, so it can't be that one. But I'd pose this to each of you: if there's just one bit of advice that you would give to somebody who may be in your shoes next, what would that be? And I guess I start with you, Commissioner Greenberg.
Well, I have three things. One is be quick to act. Two is to follow medical advice. And the third one is to have a unified action between all of your elected officials.
Okay. And I'll turn to you, Melody, if you've got anything to add on that.
Absolutely, definitely. In order to act quickly is to plan ahead. When that tsunami hits, you need the staffing to do the investigation and contact tracing. So think about how you can quickly double or quadruple your workforce. Plan ahead for either you're going to hire temporary staff or you're going to use volunteers. And then secondly, watch out for burnout, because it's going to hit, and it's going to hit hard. And 1 or 2 weeks into this working 24/7 is going to take a toll on your staff. So be prepared and keep watching for that and make plans so that they are not burning out. And then I see this coronavirus is going to go on for the next a year, 18 months, until we get the vaccine. So plan for going forward, how you can have a sustained workforce and while still taking care of the rest of public health business.
Excellent. And I'll turn to Dr. O'Connor to bring us home.
Yeah, I think you need to, in each of your communities, I think you need to think about who your trusted messengers are. That may be from governance, it may be your hospital leaders, it may be your fire EMS personnel, and think about using them to share stories to make this seem very real for people. People have a hard time understanding statistics. They understand stories. So if the first case comes in, or if someone has had an experience, or someone can convey a story from another comparable community, I think that's really important, because if you're waiting for your first case to get buy-in, it's going to be too late. If you underestimate this disease process, it's going to find you, and it's going to hurt when it does. So think about who your storytellers are, who your trusted individuals in the community are, and think about setting them up within a unified public information officer type system amongst your stakeholders. They can be a good resource to get the message out. Everybody should be on the same board and unified, as Commissioner Greenberg said, but to try to utilize those trusted voices and be consistent with that.
Excellent. It is unfortunate that Blaine County and you all were faced with one of the first waves of COVID-19, but your community clearly responded well, and I'm incredibly grateful that the three of you have taken the time to join us today and offer some insights that hopefully will prove useful to others in the coming months. With that, I think we are done for today, but I really appreciate the folks that, again, you three for joining us, but also the attendees on the webinar. And if you'd like to refer this to a friend or listen to it again, this will be posted on the Western Governor's YouTube page, which you can access if you just go to westgov.org. You'll be able to access that recording from our website. So with that, Lauren, unless you have anything additional, we're all good? Okay. Thank you so much for joining us today. Have a great rest of your day and a good weekend. And thanks so much for taking the time to join us.
Thanks
Goodbye.
for having me.
Goodbye. Thank you.
Bye.
Bye-bye.